promise it will not be long because this topic is hard. We'll talk about mainly preclinical studies. But as we already know, clinic comes from preclinical studies. So we are learning first on rats, and then we can applicate that to humans. It starts almost immediately. You can even say that systemic response to stroke that we could in fact show in our own study in Austria is within hours neutrophil blood cells are invading the stroke area within hours. So we have a little time. Because when neutrophil is there, the inflammation begins. So we need the fast and efficacious reperfusion options. Second phase begins days to weeks. This is sometimes phase of tremendous spontaneous recovery, as we can all, as clinicians, witness. Sometimes we see the patients without reperfusion therapy, with severe stroke, on dramatic spontaneous recovery. In this second phase, we have also a window of opportunity to boost this natural curing repair with physiotherapy and pharmacotherapy. Up. No. Okay, so to put it in an image context, we have neuroprotection, limit the loss of functions, neurorecovery, regenerate lost functions. How can we achieve it? Let's look at it. So, let's talk a little about neuroplasticity. This can be regarded as function of synapses, so transient or permanent as structural changes. Healthy brain of an adult had a tremendous potential for recovery, and we can this recovery promote even selective. We should be aware of it. This recovery, unfortunately, does not proceed beyond 3 months in most cases. So again, time is brain. Time is brain. Yep. So we have different paradigms. One of them is plasticity of areas of cortical representations. Then modifiable functional cortical representations. We can see these representations using advanced neuroimaging. We can discuss about vicariation, since our brain has some reserve capacity to overtake the functions lost. So once again, we should be aware of initial deficit in the patient, because we need to have some substrate in the brain left recovery to occur. So, early in the course of the ischemic stroke, perilesional region underwent many changes. So, for example, enhanced expression of plasticity-related proteins, neurotrophic factors, certain neurotransmitters are upregulated, certain are downregulated, and certain inhibitory factors are expressed. So, thanks to basic science, we can identify these key factors, and we can put the pressure on them, we can modify them with our interventions. So, how can we induce and promote neuroplasticity? So there are many non-standard measures. In our clinic we are using transcranial magnetic stimulation. One method is brutal, simplistic, easy to apply, safe to apply, when we have tremendous good results. There are different paradigms, as you can see. However, this is not limited to magnetic stimulation. We can make also vagal stimulation. It brings some success. Other such therapies as epidural cortical stimulation today presented no effect versus physical therapy alone. So repetitive transmagnetic stimulation induces electric current in the underlying cortex and can excite or inhibit the function. So we have this physical intervention, but we can also have pharmacological interventions. There are many interventions are there. We could talk short about growth factors that are known to promote angiogenesis, cell proliferation, differentiation, migration, and so on. There are many of them, as you already know. There are many studies. However, most of them are completely negative, unfortunately. Then we can talk about monoclonal antibodies. They can block inhibitory factors presented in the perilesional cortex. Unfortunately, showed also no results. So we are going on with frustration, on and on and on. So then we are going to the old friend, amphetamine. Start study, no results. Dopamine showed promising results, small number of patients. However, no further research is reported. Only in our center, we are not using dopamine to promote neural recovery, I have to say. Already mentioned flame study in the previous presentation, so I will not hang on to it. And what we are currently investigating in my center is one exciting possibility to promote recovery with 1.3 billion stem cells that we are giving in acute stroke intravenously. So this is phase 2 study. There are no results yet. But opportunity is there. Why not to use it? Possibly next year I can present more exciting result. Of course, we can talk about cerebral design. I'll shortly mention the animal paradigma. They're including middle cerebral artery in female and male rats. The many researchers have identified sonic hedgehog pathway, signaling pathway, to be responsible for cerebral design effect. They could show it elegantly in this slide. Okay, good. So you have marker of oligodendrocytes. This is the marker of oligodendrocytes, and you have marker of neurofilament of axons. So they can show that cerebral disease plus vehicle promote remineralization in preclinical, in animal setting. So this is exciting news. Further on, they can show further on in rats that different dosage of cerebral design could bring exponential effect again in rats. Small study, only 20 patients. Okay. So then we are going to clinical arena. One exciting study could show in severe, moderate to severe patients benefit from cerebralizing in Fugl-Meyer assessment score. And they can conclude that cerebral design stimulates recovery of motor functions. Then they've done some interesting study with tractography, diffusion tension imaging, up to 90 days after stroke. And they could elegantly show recovery of corticospinal integrity, protection against degeneration, structural compensation, and protection against demyelinization. Really important. Furthermore, they've done elegantly resting state functional MRI, where you can see the cerebral design patients are having more resting state activity in affected cortex, human cortex, and non-affected human cortex. This is indirect sign that cerebral design promotes network plasticity through sonic hedgehog pathway. So this is the clinical case that I had 3 weeks ago. So middle-aged man for Austria, 72 years, is middle-aged, presented to us with severe stroke symptomatic. We could show slight diffusion-weighted imaging changes in upper medulla. And we can find dissection of the left ventricular artery that is responsible for symptoms. Usually we are treating vertebral dissection that goes intradurally. We are not treating with heparin, no. We are treating with aspirin because of fear of bleeding. And the patient was, I think, after the first 2 days, he recovered rapidly. So he was plegic. The right side was completely plegic. He had aphasia, could not swallow at all. We gave him cerebralizing, and he recovered rapidly. So I could not say that this is because of cerebralizing, but it's certainly exciting to think of it. Considering brainstem recuperance possibility from ischemia, that it's possible the cerebral design advanced it. And we are coming quickly to conclusions because we are all tired. So, early neural recovery is of critical importance in the path to clinical recuperation. Time is brain, all over again, time is brain. It can be additionally influenced by some pharmacological interventions. Many of them are investigated now as plasma cells, stem cells. Fluoxetine, cerebrolizine are having most robust preclinical clinical data. We should not disregard this. We should not disregard this. We could use it, and we are using it, cerebrolizine in my setting. And other promising agents should be further investigated. Those are my conclusions. I will take questions. Thank you.